Okay. Everyone, good afternoon, and thanks for joining the latest episode of Tech Talk from Tech Systems. My name is Keith Rue, and I'm the sales manager for Tech Systems. One of the questions that is probably the most common that we get from our clients is, how can we stay abreast of the new technology that's coming out every day? And that was sort of the genesis of how the Tech Talk webinar series was born. If this is your first time on a Tech Talk webinar, we actually hold them monthly, and we try to select vendors that we think are at the forefront of the security industry, but we're always looking for suggestions from our clients as well. So if you have a particular technology that you've been wanting to see or that you're interested in, please feel free to send me an email. I'm the one sending out all the invitations, so just reply to one of those invitations, and we'll get it on the roster for you. As an added benefit, if you can't make the webinars, we do record all of them and we post those on our YouTube page. Again, feel free to send me an email. We'll send out the links to the YouTube page for you, and that way you can look not only at this webinar but at the ones that we've hosted in the past. This month, we decided to do a focused webinar specifically dedicated to addressing workplace violence in healthcare settings. We're seeing increasing news reports all the time about violence in healthcare settings, assaults in the ERs and things like that. The latest statistics show that a healthcare worker is actually 16 times more likely to experience a workplace violence episode than any other class of worker. Additionally, statistics are also telling us that over the next 10 years, home healthcare is going to increase by about 20% a year. So now it's going to be taking healthcare workers out of the hospital environment and putting them into satellite offices, medical office buildings, and even in the homes of patients in many cases. So trying to address security in these varying scenarios is really a challenging task. And so this afternoon, we're joined by Scott Campbell from CriticalArc and from Roger Ringham from Dorset Healthcare, who's actually a customer of CriticalArc. So just wanted to let you guys know we're giving you kind of both ends of the story here. We do have a vendor who can tell us about a product, but we've also got an end user and a customer who can tell us what it's like to deploy that product and how it has impacted his organization. So before I turn it over to Scott and Roger for introductions, I just want to do a little bit of housekeeping. If you could, please mute your microphones. Also, during the presentation, we do want this to be interactive. So if you have a question, feel free to chime in if there's a pause in the conversation, or if you look up at the top of your screen, you'll see a little chat button, and you can type your question in the chat there. I'll actually be putting a couple of questions in there during the presentation to kind of get some insight from the group as we go. So just keep an eye on that chat, and we'll go from there. So with the housekeeping out of the way, Scott, can you introduce yourself to the group? Tell us a little bit about yourself.
Thanks, Keith. Good afternoon, everybody. My name is Scott Campbell. I'm the Director of Sales here at CriticalArc. I'm based out of North Carolina. So being here in North Carolina, right out of college around 1995, I entered into healthcare. I was on the client side. So I was at Wake Forest Baptist Medical Center. Back in the day, it was just Baptist Hospital whenever I went to work there. So I spent about 15 years there, pretty much all in the realm of technology. So I got to see a nice evolution of things being mainframe to then switching over to local area networks. My specialty was wireless networking, and I got to work on some really amazing projects that we saw, not only giving people access to technology for the purpose of documentation, data, and all of that, but also workflow, security. There's a ton of use cases out there that started to shape over time. And really, my passion first was healthcare. Whatever I did in life, I just wanted it to be in the healthcare environment and find my place. I knew I couldn't be a bedside caregiver. I didn't have the stomach for that. But I knew that if I could find the right opportunity, that I felt like it would be a place to make a difference. After being at Wake Forest now for 15 years, I moved on up to Mission Health in Asheville, where I spent another 7 years. It was actually there, not only was I, still carrying out my technology focus, but I also got to meet the folks at TSI. So much like you are, I was a TSI customer. I worked with them on a number of different initiatives. One of probably the most prevalent one was Hugs Infant Security. But really, what I enjoyed about that experience at Mission is I got out into the various service lines and understood not only what does it take to make a hospital operate, but what are the particular pain points that we needed to take into account around safety, not only patient safety, but staff safety, especially staff safety. Um, I would say it was there that I really got exposure to, instead of there being just hospitals, and we had an abundance of hospitals here and still do in North Carolina, but they weren't operating as systems. So as the day that I went to work at Mission, literally the day after was the time we acquired the first critical access hospital, and we grew that into a health system. And as we did that, I got to see, okay, this is great how we're pushing services out into the community, but at the same time, very quickly gathered visibility on what did that mean to our safety and security. And we're going to talk about that today, and how not only how we see that in our environment, how you're experiencing that, how I, witnessed that firsthand and the technologies I deployed then, but what caused me to make that migration to the vendor side and share even a broader story with securing health systems across the globe. So thrilled to have on the call with us as well, Roger Ringham, who's with us from Dorset Healthcare. I know that Keith already gave a brief intro, but really the goal today is to give you awareness and visibility to really a common thread around the globe is the rise in workplace violence and how it's being addressed, and hopefully give you a way of maybe thinking about your approach to it a little differently. So with that, Roger.
Thanks, Scott, and thanks to Keith and to James from Tech Systems for inviting me here today. So my name is Roger Ringham. I'm a director in the National Health Service based within the UK. I'm also head of service for an organisation called Safe Security and Fraud Experts. So our remit as a team is to identify, to manage and mitigate security threats and vulnerabilities. Main two key work streams, I would say, are violence and aggression against staff and the protection of other NHS assets from theft and misuse. In addition to that, I chair the National Association for Healthcare Security, which has over 800 members here in the UK, and our remit is to professionalise security in healthcare. We also link in with a lot of other security organisations, both within the UK and across the globe. Assuming that most of this audience are within healthcare security within the States, we link in very closely with the IAHSS, so the International Association for Healthcare Security and Safety, of which a number of you are probably members. Prior to working for the NHS, I was in law enforcement. I was a detective for many years, working in major and serious crime. I then had a career change and moved to the NHS. I must say, at the time that I moved, I didn't have any idea at the threats and vulnerabilities that the NHS faced in terms of threats of violence against staff or the other security issues. So the last 15 years have been quite an interesting journey to understand what the issues are and develop systems that will keep staff safe and patients, of course.
Roger, to that point, could you tell us just a little bit about the size and the types of facilities that you're covering, number of employees, things like that, just to kind of give an idea of scale for what we're talking about?
So yes, so within Safe Security and Fraud Experts, I have a number of different clients, and just to so that everyone has a basic understanding of how healthcare works within the UK, we have what we call primary and secondary care. So primary care will be GP surgeries, pharmacies, dentists, opticians. Secondary care will be ambulance or paramedic services, acute hospitals, mental health, community. That said, of course, NHS funded healthcare services are not only provided by NHS organisations, they are provided now by many private healthcare organisations that work within the UK. In terms of what we cover, so we probably cover in the region of 30,000 staff over 1,000 sites across the UK. Within Dorset Healthcare that I actually work for, that's an organisation that covers the county of Dorset, which is in the southwest of England, and that employs 6,200 staff.
Okay, thank you. Folks, I'm going to just drop a quick little question in the chat there, just a little poll question. If you could take a look and just type an answer in the reply there, and that'll help kind of guide our conversation. So Roger, you mentioned that you moved into healthcare after a career as a detective in law enforcement, and you said that you really had no idea the challenges that we're going to be facing. So can you tell us a little bit about how that move into healthcare shifted your focus of security from law enforcement to specifically dealing with healthcare?
Yeah, so the NHS started to gather statistics in relation to violence and aggression in 2003. Under an organisation called the NHS Security Management Service, and since 2003, figures have gone up and up and up. And when I came to Dorset Healthcare, which covers a very large county and has over 309 sites, we actually then were, or if I move on to 2010 when I joined, we actually completed a return of 1,100 assaults on staff, which was very high and attracted quite a lot of attention from services such as the Care Quality Commission, the NHS Counter Security Management Service, etc., who wanted to know what those issues were. I didn't know the trust, so I said, so 1,100 assaults against staff, is that 1,100 patients assaulting 1,100 staff, or what's the breakdown? It actually worked out that there were a key number of persistent recidivists, for want of a better phrase, so patients who would continually assault staff, and there were actually a number of staff who appeared to be continually being assaulted. So it was trying to understand the demographic of that. So we started to do some quite detailed data analysis. So we looked at sites most affected, staff most affected, persistent aggressors, staff subject of serious or repetitive assault, staff-patient relationships, our reporting mechanisms, and our support mechanisms as well. And it actually brought up quite an interesting picture. About 309 sites. Actually, 86% of assaults were going on at just 5 main sites within the trust. And actually, when I looked at the assaults, there were probably about half a dozen patients that were responsible for the vast number of those, and also a number of staff that were being assaulted on a number of occasions. I remember going to speak to a service manager to say that one of their staff had been assaulted on 20 occasions over a 3-month period, to find out that they only worked 1 day a week. So I found out that whereas I thought they would bound to be full-time, they weren't. They only worked 1 day a week, and yet they were being assaulted 20 times within a period. So you have to start looking at, first of all, you need to do that data analysis to understand where your problems occur. You then need to look at training, education, and other actions that you can take to mitigate or reduce that risk.
All right, so Scott, I'll kind of pose the same question to you, but a little bit different. As you transitioned from the technology side in healthcare to now technology and security in healthcare, tell us a little bit about how that transition went and how that changed your perspective.
Yeah, so whenever I was just in IT and just making sure that networks were up and running, and transition into greater awareness of what's going on in our user community, sitting out in meetings, and they say, hey, we have this problem, we're doing these policies and procedures, this staffing model. Now when it comes to technology, what do you do to address that? And not one thing of anything that I just mentioned would fix a problem. So you couldn't just hire staff and fix it, just do a policy, just buy a piece of technology. But we all sat in this room, and as many of you on the call may have, we would sit in the room, there would be an incident, and as Roger was talking about, analyzing data, in my world, that initial view of data started with S-bars. So there was a situation, what was going to be our response? And we would sit around with someone and say, this terrible thing just happened. And, in the historic mindset of this happens only in the ED, or this happens in behavioral health, or mother, baby, labor, delivery, of domestic disturbances, things like that. We started finding as that data was growing, it became harder to profile where situations were going to happen and where we were going to be vulnerable. So for us, from a technology standpoint, they said, well, if we're pushing all these services out everywhere and we're buying critical access hospitals and we're wanting to minimize the number of readmits, so we're actually putting people out in the community to give, medical office building and clinic visits in those locations as well as home health care. What can we do to make a standardized approach from a technology perspective to protect folks? And I would say early on, just because of the development of various technologies out there, it became very siloed. We had a certain technology in a department, we had a different technology in another department. As we acquired other hospitals, we would acquire hospitals that also deployed other siloed solutions. So for me and for all the leaders involved that I was talking to, they're like, man, how can we do this on an enterprise basis and make everybody, we want to build an environment of safety that protects staff everywhere. And, we did the best we could with what we had. And some of the times, as Keith posed the question earlier, the constraints sometimes were around budget. The constraints oftentimes were around awareness of what was even available for us to deploy. So very quickly, my drive, I guess, if you would be to one, research what were the technologies out there that I could use to complement any system, process, or staffing model that we would have to address these problems. And then two, once I found that technology, or once I identified the gaps, what technology would hopefully helpfully address, as well as how could I influence visibility and awareness inside of my own organization. And listen, I really do. I miss working on the client side. As we're all familiar with doing more with less, what that turned out to be for me was, as hospital acquisitions became greater, they learned how to streamline our staffing models. And for me, being in IT, now that last hospital I worked at is now part of HCA. No one forced me out, but there were alignment of resources to where I knew that the opportunities weren't going to be as great. So then I found technology with CriticalArc that addressed the gaps that I understood for so long on the customer side, that I said, now the opportunity is there for me to take that knowledge, work on a team that is solving this problem, and bring that technology front and center to other health systems around the globe. So that's how I got here, Keith. I hope that answers your questions in terms of the progression there.
Thanks, Scott.
Yeah.
So Roger, we just started kind of breaking the surface here on lone worker and home health workers. So could you explain a little bit how the Dorset Healthcare Trust handled remote workers and home healthcare workers prior to deploying SafeZone, and then a little bit about how SafeZone helped change that approach on how you're doing that?
Yeah, so obviously lone workers can occur not only off-site, which we will talk about, but they can occur on-site. The definition that we use within the NHS is if you're out of eyesight and earshot of another colleague, then you're a lone worker. So you can be a lone worker off-site if you're going out to domiciliary visits or working in village halls or church halls or other community settings. But equally, you can be a lone worker if you're in a hospital on a one-to-one situation with a patient and clinician. There's no different. In terms of what systems we had, so we would incorporate the normal systems that people would use, such as buddy systems, chaperone. People would have access to admin teams or their managers, etc. And that's fine within office hours. But we have many staff, obviously, who work outside office hours, who work, during the evenings, during the night, at weekends, when you find that most of those other systems slip away. And the concern for us was, so how do we fill that gap? If we've got staff going out into all areas of the community, high crime areas, areas where there's heightened threats, not only because of the patients, but because of the environments they're going in. How are we going to protect those staff? And really, the only option, I think, was a technological response. We've actually used a technological system prior to SafeZone that I used for 5 years, which after 5 years we reviewed, and I said, what technological advances have you made? And I was told none. So I didn't renew with them. I looked around for something else, and what I wanted is something that I knew would keep staff safe. And obviously SafeZone does that. For those of you who don't know how it works, in the main, it works if you work out in the community. It works off of a smart device with data, so a smartphone or a tablet or similar. And basically, there are 2 alert buttons that you can press. One is for a security threat, and the other one would be for a medical emergency. What we employ along with SafeZone is we have linked in with Chubb, who are a partner of SafeZone, to supply an ARC, an alarm response center. So that looks at calls and answers calls 24/7. If they get an alert come through, they will immediately phone the caller back 3 times. If the caller doesn't answer, then they will automatically escalate that to the police. If they do answer, they will obviously ask what support they require and make sure that that support is supplied. We have teams, going out into the community. So Dorset Healthcare that I mentioned earlier, it's in the main a mental health trust. So we have a lot of staff that work within community mental health teams, crisis home support, assertive outreach. They will go out in all hours of the day and night on their own to people who are in mental health crisis, who are in very difficult and challenging situations, and they're on their own. And this is the lifeline that they have to keep them safe. They have that tool that they can call somebody 24/7, and there's someone there to answer the call. So for us, well, I felt that we had no other alternative but to employ a system like that, because I don't see anything else that fits the bill, quite honestly.
Okay. Scott, you have any thoughts to share on that, on lone worker safety?
Yeah, so just to kind of round out what Roger's saying here. So as for those of you who have not seen SafeZone, so SafeZone is a holistic safety and security platform that also encompasses emergency management and well-being tools as well. So when I was alluding to gaps earlier that I experienced on the customer side, things like being able to notify available responders wherever an incident is occurring dynamically, having dynamic updates instead of static updates, being able to protect someone in a vulnerable situation or a vulnerable location, parking garage, parking lots, their commute home, not the commute home, but the commute to their car. As they're being requested to work out in the community, and the community can consist of freestanding urgent care centers. It could be, clinics, remote locations. I mean, I know that me personally, I've been with various family members. I've had on that same care journey, be it cancer, or what other situations I was involved in. I would see providers in 4 or 5 different locations. So knowing that those staff are being called out to those areas to give a service to me made it even more aware as an employee. How do I protect those staff in those areas and give them a consistent level of response and ability to call for assistance? And then how do we empower you as an organization to be able to communicate with staff whenever a situation becomes, maybe even a larger threat, helping me if I'm in need. But if that situation and helping me you've identified is now a greater impact, how do you communicate that out in an effective way? So we've included things like mass communications that are targeted for specific areas or specific zones. One of the things that we're not going to do today is literally fire up a system and show it to you and go through a full demo. But one thing that we are going to welcome on the backside of this is the opportunity. One, we can share a brief video introduction as part of the recording that the folks at TSI put out. but we can also encourage a follow-up demonstration. I'd be happy to do that demonstration personally for you and basically share those features and functionality.
Okay. Roger, wanted to see if you could share a little bit about how you ensure that you're keeping a constant pulse on the environment of safety in your region, and how do you adjust to issues as they're coming up and changing over time?
So we work both within SAFE and within the National Association of Healthcare Security. So I chair the Southwest Region Security Management Group, as well as I chair the National Association of Healthcare Security. We are invited and go to many technical fairs, many different presentations which tell us what the latest technological advancements are. We run our own national conference where we invite a number of key stakeholders and suppliers to come and show us their latest technology. So we keep pretty well informed, and like I say, we link in with the IAHSS, and we link in with a lot of organisations that work within the States as well as the UK. We also link in with AUCSO, which is the Association of University Chief Security Officers. Many of our staff within the NHS have academic backgrounds. They have to get degrees in order to hold clinical medical posts or other posts within admin. So we link in a lot with them. So I think we've got a pretty good grounding on what's out there and what's available.
Okay. Have you had any, as the things kind of change, as situations arise, have you had any instances, has CriticalArc and SafeZone been able to address all of those? Have you had to work with CriticalArc to try and adjust some things, or tell me what the relationship's been like working with SafeZone?
The relationship, one of the positive features is that they are willing to listen. When we came across SafeZone, we made a number of recommendations to how the system could be improved. Simple things like a test button, so that if before staff went out and were deployed, within their rounds, etc., they could test the system to make sure it's working. There's nothing worse than going out and trying a system to find that it doesn't work. So a simple test button was introduced. Secondly, because I've become from a police and law enforcement background, I very much look at evidence. So if there is an altercation between two people out in the community and a threat is made, and we do, even in the southwest of England, in the sleepy county of Dorset, we have what's termed in this country as unlawful imprisonment, whereby people are clinicians go into houses, people refuse to allow them to leave. We do have sexual assaults, we do have physical assaults, we do have allegations made against our staff. And of course, if I'm in a room with somebody else, it's my word against theirs, and there's no evidence as such that incident has taken place. What SafeZone does is you press an alert button that will put you in touch with the ARC, the alarm monitor response center, and they will phone you back. But actually, there's no evidence as to what's actually occurred. One of the suggestions that I've made that SafeZone are taking on is to say, right, as soon as I press that red alert button, the device will start actually recording what is going on. And that recording can then be used in any court process. So the shouting and the screaming, the threats that are made can all be heard. And that's an evidential process. I put that to the, sorry, Scott, I'm just going to say the technical boffins from SafeZone. And that's certainly something that they've taken on board and is something I know that they're introducing. So we've made several suggestions to how SafeZone can be improved, and I've got to say every single one of the suggestions that we have made has been taken on, and we've been given assurances that it's fitting in, with how that they develop the system. So that's worked very well.
Scott, you want to say a little bit about how that works, from
Yeah.
the other side of the equation?
Yes, if I can just add to that, one, this is one of the reasons why we love Roger as a customer. It's not just him; it's all of our customers that we're listening to. We don't just have customer service; it's customer success. That's our strategy, and we're currently retaining 99.3% of our customers. Meaning we're not losing customers once they're safe zone customers, and that's over a 10-year span. So quite an impressive track record. It's not just about statistics, it's about really providing meaningful results. And for me, when I think about the various systems I supported as a client and I wanted a vendor to implement certain technology enhancements, build a relationship with me, help me get to the point that I'm actually bringing you value. So it was refreshing to hear that, as part of the onboarding process. As I came here a little over 3 years ago now, it was refreshing to hear that is our focus, and to meet the customers and to hear and to see the development sprints that says, hey, this customer brought forth this request. This is when we're going to actually put it into a development sprint. This is when it's going to be tested. This is when it's going to be released. We tell people all the time, and it's true. You're not investing in a technology, though you are getting a technology. You're investing in a relationship, and one that would bring forward. We start where we start today, and then as we progress forward, and you give us additional feedback on how the technology is working in your environment, we can take that and make the product even more powerful, so it is a greater impact to our entire customer base. We do a user group every year, and so far this year we haven't done one 100% in the U.S. To date, because we started in Australia, then we went to the UK. But this past year we did user conferences in both locations, and we're going to add in this upcoming year. We're adding a U.S. user conference as well.
Great. So Scott, not Scott, I'm sorry, Roger. Now that you have got this implemented, and you're proactively looking at how the environment is changing, how things are adapting, how has this changed the culture of your organization and the perception of security from your staff? Because it's not just about making sure that they're secure, but it's also letting them feel that they're secure. So kind of how has this impacted your organization?
Well, it is, and I think you need to look a lot deeper into the analysis I talked about earlier on, because something that we look upon it in terms along the same as the incidents that take place. We look at the workforce metrics, so we look at things like sickness, absence, recruitment, and retention. Now, if you look at Dorset Healthcare, I can tell you that the average sickness absence is about 4 to 6%. However, when you start looking at the services where there are much higher levels of assault on staff and much bigger threat to staff, then that can go up to 20%. There are significant sickness absence issues and recruitment and retention issues. The NHS is suffering an acute shortage of staff. We look at a number of professional organisations such as the General Medical Council, the Nursing and Midwifery Council, the British Medical Association, who all produce figures and stats on workplace violence and the effect that that's having on staff in terms of sickness, absence, recruitment, retention, and those who choose not to stay. We've got 128,000 nurse vacancies across the UK. We've got 5,000 doctor vacancies across the UK, which we cannot fill. Our NHS teams go all over the world trying to attract people into the NHS from other countries to come here, to be given obviously status to stay and work in the UK, to have bursaries paid to them, because it's a difficult environment to come and work in. So as much as staff want to feel that they've got a good career pathway, that they've got a good salary, they want to feel safe and they want to feel secure. I mentioned those horrific figures earlier in terms of 1,100 assaults on staff. Year upon year, the national figures have gone up. Our figures have gone down. This year, we're going to report somewhere in the region of 500 assaults. We've seen something like a 50%, 51% decrease. We've done that by a number of different systems that we've employed, one of which from a lone worker perspective is safe zone. And if we can do that, I mean, we haven't talked about other facets. For me, the priority was looking after our lone workers. And like I said earlier, yes, that's those out in the community. And it's true to say that those who work in a hospital or some other on-site environment, they've probably got a number of other physical security measures protecting them: CCTV, pit alarms, access control, etc. But they can be, they can have equal issues, which is why actually we will be rolling Safe Zone out as a desktop service very soon. But in addition to lone working and that, we've also got wellbeing assistance, which will be rolled out soon. Mass communications, it has already been talked about. Two-way messaging, tip reporting, with an information bar which tells people where they can get a number of support mechanisms if they need it. Occupational health and wellbeing, and other types of support. So it really is a holistic service that, as we develop, we will get more use of. But as I say, my main priority, we've got out of 6,000 staff, lone worker wise, we've got 2,000 on the system since February. That's been a mammoth task. And again, we've been supported a lot by the Safe Zone team in order to have that success and get those people on the system and get the system working properly. So, and we already know, because we link in with unions, that this system has been well accepted, and people like to feel safe. As I say, and this helps them to do that.
So as you think about that, sorry, Keith, I'm just going to jump in here.
No, I was just going to ask you if you knew of any other common themes that we're experiencing to kind of piggyback on Roger's comments.
Yeah, so when you think about that environment of safety and wanting to feel safe, I mean, the notion of the fear of crime, the fear of violence is driving so many behaviors in our society today and around healthcare. We're at no shortage of examples we could provide where that is actually playing out. And, one thing I want to stress about what Roger's saying, if obviously, I think he said over 6,000 employees. They have services that we would equate to being a main hospital, critical access hospital, clinics, and community health. So as we've talked about the various use cases, as he ran through that litany of use cases just a second ago, that he was naming features and functionality that are within the Safe Zone platform. But what's really, really powerful to understand here, so many times I was sitting in leadership meetings and they're like, how can we address all of these situations? And when you find a policy, procedure, staff, and even technology that will fit the bill, that doesn't mean you can necessarily do all of that at once. Is that something you can take on? Or is there one gap that you're holding out for that's minimizing your effort? So what I wanted to stress here is we absolutely adopt a land and expand strategy. So if you said to me, hey, Scott, we want to address safety and security in the community first. Hey, Scott, we want to address vulnerable areas inside of our hospital, our main campus first. We want to do a specific use case. We want to do only staffed arrests. We want to do, we don't want to do, or we do want to do mass comms in the future. That's fine. Those are all land and expand strategies. And I think that, Roger, as you're saying that, I just want to emphasize, I think one of the things that we do get hung up on really globally is how do we do it, and how do we basically boil the ocean and do it all right now? I do think that plans, and we can help you with determining what is the right plan for your organization and roll out in a very complementary way. But the themes that we're hearing, so we've all seen this, doing more with less. Our budgets become more constrained, our demands to see more patients rises, to compete with neighboring systems. And whenever you do that, the themes that start recurring are, how do we maintain consistency? How do we give everybody the same method to call for assistance? How do we give our teams, how do we equip them with quicker response times, greater visibility, without compromising any integrity of privacy? The list goes on and on. So when we're seeing those themes and And they're very real. They're very real situations that are impacting our recruitment and retention. They are recruiting, or they are impacting our basically our shopping experience. As people are looking at the brand and where would they go be seen in the community, if an environment feels unsafe, that does impact not only your workers but your patients and visitors that would come to those locations. So those are themes that we hear. Those are areas we definitely try to address as best as we can. So we're going to continue to do that.
All right. Roger, in your introduction, you said, you're a man wearing many hats right now. You've got your fingers in a lot of different pots there. So just kind of switching hats for just a second. We've heard a lot about your experience with Dorset Healthcare Trust. Talk to us a little bit about being the chair of the NAHS and how, what is your vision for the future of security in healthcare?
Well, our vision is quite simply, or our strapline is to professionalize security in healthcare. We are developing training for security officers and security managers and a defined career pathway. We are linking in with regulatory and supervisory bodies to develop a set of common standards for security managers within healthcare to follow, so that we have got a consistency of approach across healthcare. And I think that that's badly needed. And fortunately, the powers that be are listening, and that's a piece of work that we're doing at the moment. More than that, I can't really say. It is simply that. It is to professionalize security within healthcare and have a consistent approach. We've put together a very good team of subject matter experts to develop those processes. This morning, I met with a guy called Nick Oldworth, who is one of the leading authorities in the UK on counterterrorism. And so we're looking at how we can develop counterterrorism protocols for the health service because we're not immune to attack. So it's developing with the right people, the right standards to make sure that we've got a consistency of approach.
Okay. Kind of switching back to Dorset Healthcare a little bit, what does the future hold for you there? You mentioned, rolling out some other pieces of Safe Zone like the mass communication and things like that. So kind of, how does that rollout process work? How do you implement that over time? And, what does the future hold for you?
Well, this year I've signed off on a number of new projects. Like I say, Dorset Healthcare is mainly mental health and community. But, we have PICUs, psychiatric intensive care units. We have low secure units, which are people that would be in prison, not if it wasn't for their mental health conditions. So we deal with people with some quite severe and challenging behaviours. The patients that we are seeing, people are becoming more acutely unwell as time goes on with much more complex healthcare needs. And as we said earlier, a lot of that will be delivered in the community, especially with new technology. So keeping people safe while they're trying to deliver those more complex services with people with more complex needs, that's where we're going to have to rise to the challenge.
Okay. You had mentioned when we were talking a little while ago about some unique ways you were going to use the mass communication module, more than just broadcasting out, hospital-wide messages or healthcare-wide messages. But you had mentioned it in terms of helping staff communicate with each other in terms of filling needs and such. Can you expand a little bit on that?
Absolutely. I mean, to be honest, these systems are only subject to your own imagination, what you can use them for. Certainly in terms of the mass communications, if there was a particular security threat within an area, we could obviously communicate to staff to avoid that area or go to a particular area. But equally, if we were looking for the urgency of requiring a diabetic nurse or a piece of medical equipment, such as a syringe driver, and we needed to locate one earlier, we could put out a mass communication. And the beauty of this system is that you can you can very much define who you send it out to. With a lot of systems, it is a global system. You send this message out and it goes to many, many people who actually shouldn't have that message. With this, you can very clearly define the staff, the services that you require to notify. So if you need a particular expertise, you can put a message out there and find a diabetic nurse. If you need to find a piece of equipment, you can find it. So you can use it for a lot of practical other solutions as well, not just security.
Okay. So Scott, where do you see CriticalArc taking SafeZone next? What's the future of CriticalArc and SafeZone?
Yeah, so we're still gonna keep the course with what we're learning from our users, from our customers, and that is always keeping a close ear with them and knowing, anticipating as best we can by listening to national statistics and averages, those sort of things, but also listen to our customers and hearing real world field knowledge. What are they experiencing? What are their pain points? They have the best recommendations and the best, I guess, insight that we can have. So maintaining those relationships, continuing to stay very engaged with our trade associations. So like when Roger mentioned IAHSS, OXO, IACLEA on the university side, we're staying very much engaged with those trade associations, making sure that it's not so much about promoting the CriticalArc name as it is giving something back and understanding where do we fit in that can be very complementary to our customers and prospects. We've added in some additional services beyond just providing technology. We've added a consulting arm to CriticalArc as well. We've obviously built partnerships such as yours, Chubb as well. That we, when Roger was speaking earlier, he was mentioning Chubb, which is very much like TSI as well, to meet a need where if there's a comfort level or an existing presence of a partnership that we can leverage basically a common knowledge and service delivery to those customers in a very powerful way. So we're going to continue to do that and really just welcome the opportunity to offer a transformational way for folks to respond and communicate with their staff around a culture of safety. And I do look forward to continuing conversations with folks on this call. If you want to reach out directly through your TSI folks and connect with me, if there's additional customers we would want to link you with or interest, then we would find a way to do that as well.
Great, thanks, Scott. So, back to the group now. Is there anyone on the call right now? And remember that, we all started muted. So if you want to speak up, go ahead and unmute. But are there any questions from the group for Scott and Roger while we're all still together?
I have a question, Keith.
Sure.
So, during the course of the conversation, we've talked a lot about, the risk involved in not taking certain precautions. And my question in this situation is, how do you determine the actual, like when you do a risk assessment on what's necessary, how do you determine viable numbers that you can say, okay, this isn't a spend, this is an investment, and in other words, it shouldn't cost anything. It should be preventative money. So how do you come up with the data that supports that argument?
Roger, I'll let you take that one.
As I said earlier, we do detailed data analysis, so we know how many incidents occur, how many staff are physically assaulted, sexually assaulted, racially abused, unlawfully imprisoned, and a number of other physical security measures that we look at as well. In addition to that, as I say, when we look at workforce metrics, you can look at the sickness absence, the recruitment and retention issues in those areas. If you have sickness absence within key areas such as mental health due to violence and aggression, then you look at also the bank and agency spend, which literally will go from hundreds of thousands to millions. So you can very easily, I would suggest, build a picture, if you look in the right place, of what that is costing the organization. the litigation as well, the person, where people will sue the organization to say, you haven't kept me safe. You had a duty of care under law to keep me safe, and you failed to take the appropriate measures. There are a number of different markers that you can use, as I say, and I tend to do that now, because I can, with these statistics, we put this up in Power BI charts or SPC charts, and we make it look very great with all these trends, and we talk about the amount of incidents. But you need to speak the language of different people. So as I say, when you're speaking to the people and culture or HR, you talk about that sickness, absence, recruitment and retention. When you're talking to the director of finance, you talk about the bank and agency spend and the money cost of it. There are a number of different markers that you can employ to say this will reduce this. We saw a reduction, certainly in bank and agency spend within mental health, from 2 million to 400,000. That's a 1.6 million saving. Security measures don't cost, that we're talking about, don't cost anything like that.
Is there, if a facility, let's say we're talking about investment in, peripheral areas instead of the main facility. If a company doesn't take, what's the base level? I guess what I'm getting at is, what's the litigation risk if someone should have done something, or they could have done something and they didn't, and something awful happens? I guess that's where I'm going with this, is how do you balance that equation, and how do you say, okay, well, are we exposing ourselves to litigation if we don't do something?
Within the UK, there are many laws and legislation which say that you, as an employer, have a duty of care to keep your staff safe and secure whilst they're at work, and that you must. I don't like using the term risk assess, because when we talk about security, we talk about threats and vulnerabilities, because we are looking at hostile actors who intentionally are causing a threat to staff. So for me, they're always threat and vulnerability assessments. But so you have to reasonably assess the risk that staff will face. So if you've got staff going out into the community, we already have a database that tells us these are the incidents that staff will suffer whilst they're out in the community, especially if they're in certain areas, high crime areas, or dealing with patients who may be displaying challenging behaviour. So the data is clearly there. You cannot say, I don't know that happens,
Right?
because you will have a history of data which tells you it does. So you therefore have to take appropriate measures to keep staff safe. It's not a case of how do you justify doing it. I would turn that on its head, David, and say, how do you justify not doing it?
Right. Yeah. Well, I mean, and we recently had, I'm sure everybody knows, we recently had an event here in Atlanta where someone went into a satellite office and had a gun. And I remember watching it at the time and telling my wife, if they had had certain measures in place, that wouldn't have happened. How responsible is the company that should have done it? I guess is what I'm asking, and you seem you answered it. So
one
Got
thing
anything
that
to
I
add
would-
on the US side of it?
Yeah, just a couple of things here. One, I learn something every time I listen to a customer, and I learned something additionally today. And when Roger's talking about the data analysis to know what problems exist, but to carry that forward and say, I've implemented a solution or several solutions. I've implemented these processes, this model, and now I've got measurable data on the back end of it. When I see a trend in my country in this sector going up, and my trend is going the reverse of that, well, what was it that points to that? So for us as a vendor, we're trying, and we're succeeding in this. How do we not just become another response mechanism, but how do we become a mitigation mechanism?
Right.
How can we deploy features and functionality that would allow you to prevent a level of crime that you otherwise it's not about allowing it to happen. You just hope it doesn't happen in your environment. And when it does, then you spend the money to do it. So I see that. I can't speak to what are the risk assessments that every single hospital typically engages in here in the U.S., but I can tell you it seems to be quite reactionary to when we've had this situation happen. What do we do now? And hope that they hit the target. And a lot of times, to be honest with you, an irrational decision could be made because it's a rush decision, and it's let's overspend and let's get the wrong process, procedure, technology, staff in place to address it.
Okay.
Thanks,
Well,
guys.
we've got just a few more minutes in the hour here. Do we have any other questions from the group before we sign off? All right. Well, Roger and Scott, thank you very much for joining us today. To the rest of the group, I hope that this was a beneficial use of the hour, and I hope you enjoyed being able to kind of hear both sides of the coin here, not just having a vendor talk about their product, but also getting to hear the perspective of a customer who has implemented that and is using it. So really look forward to hearing some feedback from the group. And again, I thank you very much for your time. Have a wonderful day.
Thank you.
Thanks, everybody.
Thanks.
Thank you.